Hi, welcome to the lang page. Today we are going to discuss about 2024 revised ISHAM criteria for ABPA and ABPN management and diagnosis strategies. What are the things they updated new in this guideline? So very simply we can see here in within 5 minutes of time how can we manage ABPA and ABPM. Okay, we'll see. So in this 2024 recent guideline, what are the changes they did in this guideline from the previous? So here very important changes they did because the serum total Ig cutoff level, those previous guideline that was 1000, now they reduced up to 500 because that increased the sensitivity to 98 percentage. Then they come to modernized tools and therapeutics. So those days we are did a skin prick test. Now they more favor of IgE immunoassay. So these are the main changes they did in the 2024 ISHAM criteria guideline. So we'll see one by one. So who are the people we are going to target, or who are the people we are going to screen for the fungal sensitization? For an example, adult patient. All the adult patient newly diagnosed asthmatic, newly diagnosed asthmatic adult patient, we have to screen about ABPA or ABPM. In pediatric population, we have to screen only this child difficult to treat asthma. So that is pediatric category. So what are the preferable investigation tools we have to do? So aspergillus specific IgE cutoff is 0.35. So secondary tool is a skin prick test. Okay, so very clear cut. In this slide, we are going to see about what are the biological markers or what are the investigation or diagnostic tool we are using to identify ABPA and what are the cutoff. So especially we are doing total IgE levels. So cutoff is more than or equal 500. Blood eosinophil count again more than or equal 500. Aspergillus specific IgG, so in India is more than 27, UK more than 40, Japan more than 60. So it's population specific, so it's vary about population IgG level. And also we can use recombinant antigens, so usually these are not commonly used in the our country setup. Here we can see about diagnostic criteria. What are the diagnostic criteria of ABPA and ABPM? So ABPA means allergic bronchopulmonary aspergillosis. ABPM means allergic bronchopulmonary mycosis. So predisposing condition should be there: asthma or cystic fibrosis or COPD or bronchiectasis for both condition. Then essential components are there. That is in ABPA means allergic bronchopulmonary aspergillosis. So aspergillus specific IgE more than 0.35 and total IgE more than or equal 500. Like that here ABPM aspergillus specific IgE must be less than 0.35 and also IgE level more than 500. And additional requirements any of two like any other IgG positive or aspergillus IgG positive or maybe an eosinophil more than 500 and also image findings. Like that here also eosinophil 500 and any other fungal positive IgE and image finding. So these are the diagnostic criteria. In addition, there's a high attenuated mucus noted in the CT that is pathognomonic to ABPA or ABPM. So even we don't have any essential component, so we can confirm the diagnosis with this CT. So now clear, right? Now we can move to the diagnostic algorithm. How we can diagnose ABPA or ABPM. So patient with predisposing condition like COPD or cystic fibrosis or asthma is not settled or difficult to treat. So then in setup we suspect as a ABPA. So we have to check the aspergillus specific IgE level. Then IgE levels more than 3.5, more than 0.35, we suspected as ABPA. Then we have to do the our essential criteria total IgE level that is more than 500. So we diagnose as ABPA. Then we have to confirm with two additional criteria with blood eosinophil count and aspergillus IgE level. So then we confirm the ABPA. But anyhow, we have to do the HRCT test to phenotype. What phenotype of this ABPA? So we'll see later what is the phenotype. Then again here is less than 0.35, we suspect it as a ABPM. So then we will require the non-aspergillus specific IgE sensitization and total IgE. So this is the diagnostic algorithm. Okay. Now we are going to phenotype the ABPA. That means radiologically what type of ABPA is it? So like that. So when we see it's ABPA-S, ABPA-B, ABPA-MP and ABPA-HAM and ABPA-CFP. So this is how they classified in the phenotype with the HRCT. ABPA-S means that is serological ABPA-S, but there's no bronchiectasis evidence in the HRCT. In ABPA-B, that means radiological evidence of central or peripheral bronchiectasis, mainly central bronchiectasis. ABPA-MP means mucus plugging, bronchiectasis plus non-hyperattenuating mucus that indicate the greater immunological sensitivity. So ABPA-MP. But here is a very important thing. ABPA-HAM, HAM, that means high attenuated mucus. That mucus visuality denser than paraspinal muscles, that is pathognomonic to ABPA or ABPM. Then again we can see the severe form is a chronic pleuropulmonary fibrosis. So it's lead to fibrocavitated lesion and fungal balls are there. So this is the phenotype of the ABPA or ABPM. Okay, now clear. So we'll move to the next. So the clinical classification of clinical stages of ABPA, that means acute ABPA. So newly diagnosed or exacerbation. So in this exacerbation stage, patient have a more than 50% rise of IgE level from the baseline. Response mean more than 50% symptoms improvement and radiological clearance is there, and more than 20% of drop of IgE in 8 and 8 weeks. That is response. Remission means sustain for more than 6 months clinically and radiological improvement with off glucocorticoids and no 50% IgE spike. So IgE spikes are in the baseline. So that is remission. Sometimes the patient treatment dependent. That means 2 or more consecutive exacerbation within 3 months of stopping steroids. When you stop the steroid, the patient develop exacerbation. So that is treatment dependent. Some advanced cases, this patient presented with extensive bronchiectasis, copulmonale and type 2 respiratory failure. So this is the clinical stages of ABPA. So previously we saw the phenotype. Here we can see the clinical stage. Okay, we'll move to the next. So what are the treatment? So first line treatment of ABPA, that means acute ABPA. First we have to treat with the systemic glucocorticoids. So prednisolone we have to take, ask the patient to take 0.5 milligram per kilogram for 2 to 4 weeks and rapidly tail off over 4 months. And another pathway B is there, steroid sparing azoles. That means oral itraconazole 400 milligram daily for 4 months. That is the first line if the steroid are contraindication, like the patient obesity and also diabetes mellitus and osteoporosis is there. So we can directly start the itraconazole. So what are things we do not use means initially we don't combine with these two drugs, steroids and antifungal initially in the acute stage initially, and also we don't use high dose, and also initially we don't use the biologics in the first. So asymptomatic ABPA systemic therapy not routinely recommended. So when asthma control is very poor only we can use for the glucocorticoids. So what are the managements during the exacerbation? The patient presented with sustained clinical worsening for more than 14 days. So we suspect asthma exacerbation. So no radiological deterioration and stable IgE level. So we can treat as a asthma. So infective bronchiectasis, so treat as a infective exacerbation of bronchiectasis. In true ABP exacerbation, so what are the finding of ABP exacerbation? As I mentioned previously, new radiological infiltration, more than 50% rise of IgE from the baseline. So these are the indicator of ABPA, so exacerbation. So in this setup, what are you going to do? Initially treated with the glucocorticoids in the first exacerbation. Okay, then if the recurrent exacerbation is there, we can go for the prednisolone or itraconazole. This is how we'll manage the exacerbation. Okay. So management of treatment dependent ABPA. So previously I told what is treatment dependent ABPA. Treatment dependent ABPA means patient failing steroid tapers twice or experience more than 2 exacerbation within 3 months of steroid cessation. So when we stop the steroid, patient develop exacerbation. So more than 2 within the 3 months. This is called treatment dependent. So in this situation, what are you going to do? Initially, so in guideline, they recommended uh, biologics, directly start the biologics, or otherwise, second option, we can go for the long-term azole therapy, oposoconazole, isavuconazole, or otherwise we can option 3, we can nebulize the amphotericin B. So last option only we can go for the low dose systemic steroid because of the side effect profile. So pharmacological, we all know glucocorticoids, what will happen, it will lead to Cushing syndrome and a lot of other problems. When we give it itraconazole, so in itraconazole and methylprednisolones, so itraconazole increase the plasma level of methylprednisolone, so increase the exogenous high risk of Cushing syndrome. So if we give antifungals, ask the patient to take with the meal, so that will increase the bioavailability. So these are the main thing about the pharmacological. So how can we assess the response? That is very, very important. So assess the patient's response 8 to 12 weeks. That is a milestone for checkpoints. So what are the things we have to check in the response? So usually we have to check in the 12 weeks. So first, clinical goals. So we have to assess the patient with the visual analog scale with more than 50% of the symptom should be improved. Second, immunological goal is very, very important. So we have to do the total IgE level. So that is more than 20% reduction of the acute peak. That is indicate the patient have a good response. So almost always remember that IgE will not normalize from the baseline, come to the lower baseline. So if it's reduced to 20%, so that will take as a benchmark for the future exacerbation. Radiological goal, that is very important. Major clearing of pulmonary opacities, more than 50% of the reduction in the chest radiograph, or we have to do the HRCT. Okay, so very, very important things we can do is do not use the aspergillus specific IgE or IgG or blood eosinophil count to monitor the response. They are not reliable for the treatment response in the in the ABPA or ABPM. Okay. So then we have to move over the glance, how the complete clinical pathway of ABPA, how we can monitor the patient of the ABPA at glance. So here we can see predisposing factor, asthma or cystic fibrosis or bronchiectasis. Then we have to do the biological marker like total IgE level more than 500, eosinophil more than 500, aspergillus specific IgE or IgG positive more than 0.35. Then we have to phenotype with the CT. Then we have to intervene. That's if it is the acute ABPA, we have to start with the monotherapy with the whether initially we start with the corticosteroid or itraconazole for 4 months. So this is monotherapy. Then we have to check after 12 months, 12 weeks of the treatment, evaluate the clinical and immunological and radiological response. Then the patient enter is stable, so IG becomes stable at the new baseline. So the patient is stable, so we have to off the steroid. Then patient still exacerbation or patient have treatment dependent, we have to identify why this patient have frequent relapse or why this patient have infrequent responses. Then we have to exclude other causes. Then we have to start the combined therapy with oral corticosteroid and itraconazole. Then again assess treatment dependent ABPA. So the patient require continued therapy to maintain the remission. So if we drop the dose of the steroid, patient develop again exacerbation. So that's indicate treatment dependent. Then we have to go for the biologic or long term azoles for this patient. So this is the complete ABPA management at glance. Okay, so very important for pearls in our daily practice about ABPA or ABPM according to the new guideline. This is a summary: is screening the patient selectively. So screen all new adult onset asthmatic patient. Okay, but in the pediatric population we have to identify or screen difficult to treat pediatric asthma cases. Second, lower thresholds. That means total IgE diagnostic is now more than 500. Those days that was in 1000, now it's reduced to 500. That will capture the ABPA very early and will manage very easily. Then another important thing is look for high attenuated mucus in the HRCT. That will confirm the ABPA without these essential criteria. So another important thing is track total IgE, not specific aspergillus specific IgE. So monitoring the success as 8-week or 12-week with a more than 20% drop in total IgE. So almost always remember, never use specific IgE or IgE to track or identify or recovery. Okay, now we clear about this ABPA. Thank you very much. So this is my page. Follow and subscribe in the YouTube, Facebook, and TikTok as well. So stay tuned. We'll do the more interesting videos in future. Bye.